Hematological malignancies. Welcome to this episode. So far, we've had a look at the different groups of hematological malignancies. In this part, we will be assigning the most important diagnoses to these groups. Acute leukemia. The classification of acute myeloid leukemias is done according to the FAB classification. Although it's an older system, it still remains commonly used. The term FAB stands for French, American, British, and refers to an international team of hematologists who were involved in its development. The FAB classification system is based on tumor cell morphology under the microscope. Before we go into the individual diagnoses, the following can be generally said. The myeloid cell line is composed of many different cell lines. From the precursor cells of each cell line, hematological malignancies may arise. This can be from the precursors of granulocytes and monocytes, from megakaryocytes, or from the precursors of red blood cells. As there are many different cell lines with discrete morphological features, the FAB classification system for the myeloid malignancies differentiates more subtypes than for the malignancies of lymphoid origin. Currently, there are 8 groups, which are termed M0 to M7, with M indicating myeloid. These are the subtypes. In this episode, we won't discuss the individual subtypes in detail. However, here's a short note for your understanding. The most important cell lines of myelopoiesis can be found in this classification system. For example, M3, the acute promyelocytic leukemia, originates from the granulocyte line. This is important to remember because patients with this leukemia show a severe bleeding tendency. Other acute myeloid leukemia subtypes based on the FAB classification system are M5, M6, and M7, or acute monocytic leukemia, acute erythroid leukemia, and acute megakaryocytic leukemia, respectively. The names of the subtypes are a good indication of their origin. Apart from the FAB classification, there is also the newer WHO classification for acute myeloid leukemias, which is based on molecular genetic findings. This is a much more abstract approach, but is advantageous in the sense that molecular changes are tightly associated with the aggressiveness of disease and treatment options. For the acute lymphoblastic leukemias, the FAB classification system is outdated. It previously served to differentiate the acute lymphoblastic leukemias into the following groups: small uniform cells, large varied cells, and large cells with vacuoles. However, the use of morphology to determine the cellular origin is a poor criterion. The FAB classification of acute lymphoblastic leukemias has been replaced by the accurate identification of cells using immunophenotyping. Cell surface marker expression can be used to differentiate the acute lymphoblastic leukemias into the B-cell and T-cell leukemias. B-cell leukemias can be subdivided into precursor B-cell acute lymphoblastic leukemia and mature B-cell acute lymphoblastic leukemia. Precursor B-cell acute lymphoblastic leukemias can be further distinguished by their immunophenotype into early pre-B acute lymphoblastic leukemia or pro-B acute lymphoblastic leukemia, common acute lymphoblastic leukemia, and pre-B acute lymphoblastic leukemia. The immunophenotype of cells in acute lymphoblastic leukemia correlates with the stages of normal B-cell development. For comparison, let's go back to B-cell maturation, which was shown in Part 1 of this topic. Here we can find the pro-B cell, pre-B cell, and mature B cell. The maturity level of cells from common acute lymphoblastic leukemia lies between pro-B and pre-B cells. It is termed common because it is the most frequent form of acute lymphoblastic leukemia, accounting for approximately 50% of cases. The T-cell acute leukemias are also categorized by their level of cellular maturity. Without going into too much detail, they are classified into 3 forms: early T acute lymphoblastic leukemia, intermediate T acute lymphoblastic leukemia, and mature T acute lymphoblastic leukemia. Division into these groups is made according to specific cell surface markers and flow cytometry. In addition to immunophenotyping, the WHO classification has also gained importance in classifying acute lymphoblastic leukemias. Apart from their cells of origin, let's have a look at some more differentiating features of acute myeloid versus acute lymphoblastic leukemias. One example is age distribution. Acute lymphoblastic leukemias mainly occur during childhood, whereas acute myeloid leukemias occur during adulthood. This age distribution is based on a fundamental difference between lymphocytes and cells from the myeloid line. T cells and B cells are part of the adaptive immune system and can react specifically to various pathogens. The foundation of this specificity is the diversity of antibodies and T cell receptors. But how does this diversity arise? It is achieved by gene rearrangements during lymphocyte development. The entire process is termed somatic recombination. Somatic recombination also poses a risk, as the slicing and merging of DNA can lead to errors. This particular mechanism is the key to understanding the age distribution of the acute leukemias. The adaptive immune system develops the most in the first 20 years of life and is the reason why acute lymphoblastic leukemias more commonly affect children and young adults. In contrast, the development of acute myeloid leukemias is favored by toxic chemicals like benzene or ionizing radiation. Because a certain exposure time is necessary for developing acute myeloid leukemia, it is most commonly observed in adulthood. So let's summarize the most important points of the acute leukemias. The FAB classification can be used to categorize the acute myeloid leukemias into different subtypes based on morphology. In acute lymphoblastic leukemia, classification is made according to immunophenotyping, and in particular, the level of cellular maturity. The WHO classification system is most current and is based on genetic alterations in leukemic cells. An important difference to remember between both acute leukemias is the age distribution pattern, with acute lymphoblastic leukemias being the most common type of malignancy in children, and acute myeloid leukemias being most commonly observed in adulthood. Now let's move on to the lymphomas. Lymphomas are classified into Hodgkin lymphoma and the non-Hodgkin lymphomas. Hodgkin lymphoma was first described in 1832 by the English physician Thomas Hodgkin. In classical Hodgkin lymphoma, a hallmark histological feature are Hodgkin and Reed-Sternberg cells. A much less common form of Hodgkin lymphoma is the nodular lymphocyte-predominant Hodgkin lymphoma, abbreviated as NLPHL, which accounts for only 5% of all Hodgkin lymphomas. Hodgkin and Reed-Sternberg cells are not present in non-Hodgkin lymphoma. There was an initial distinction to the other previously poorly characterized lymphomas, which were grouped as non-Hodgkin lymphoma. The historical classification into Hodgkin and non-Hodgkin lymphoma is unfortunate because non-Hodgkin lymphomas represent a heterogeneous group, often with very different characteristics. Non-Hodgkin lymphoma can be classified according to its prognosis into high-grade aggressive non-Hodgkin lymphoma and low-grade indolent non-Hodgkin lymphoma. In the following, we'll briefly present the most important non-Hodgkin lymphomas. The most common non-Hodgkin lymphoma is diffuse large B-cell lymphoma. It is a high-grade, aggressive form of lymphoma. The second most common non-Hodgkin lymphoma is follicular lymphoma, which is a low-grade lymphoma. Multiple myeloma is also considered a low-grade non-Hodgkin lymphoma. The malignantly transformed cells migrate to the bone marrow, making this a lymphoma with bone marrow infiltration. Burkitt lymphoma is an aggressive non-Hodgkin lymphoma that is uncommon worldwide. However, it is endemic in equatorial Africa and other tropical regions. Lymphoblastic lymphoma is another aggressive non-Hodgkin lymphoma that is relatively rare. It is quite special in some respects. In the first part, we mentioned that lymphomas primarily arise from the mature stages of cell development. However, lymphoblastic lymphoma develops from the precursor cells of lymphocytes, and therefore the same cells as the acute lymphoblastic leukemias. It is namely a variant of acute lymphoblastic leukemia with peripheral manifestations such as lymph node swelling. However, there is little bone marrow involvement. Now on to another disorder that belongs to the indolent non-Hodgkin lymphomas, namely chronic lymphocytic leukemia. Chronic lymphocytic leukemia may be termed leukemia, but it is actually a lymphoma because malignant transformation does not occur in the bone marrow, but in the lymph nodes. The malignantly transformed cells then enter the bloodstream, which is why chronic lymphocytic leukemia was initially considered a leukemia, but more accurately, it can be termed a lymphoma with a leukemic phase. For a deeper understanding of the lymphomas, assigning the diseases to their cells of origin can be very helpful. Precursor B-cell lymphoblastic lymphoma arises from pre-B cells. Chronic lymphocytic leukemia arises from mature B cells, but may demonstrate characteristics of memory B cells. Multiple myeloma arises from plasma cells. Most lymphomas, however, originate from activated B cells. Examples include follicular lymphoma, diffuse large B-cell lymphoma, and Burkitt lymphoma. Activated B cells are B cells that have been activated in the germinal center, where they pass through several stages. These activation stages appear to represent a risk for the development of certain lymphomas. In fact, an interesting mechanism has been identified in recent years that contributes to the development of these lymphomas. The most likely mechanism is antibody class switching, for example, from IgG to IgA expression. Without going into too much detail, a class switch can only occur if the DNA is cut in the initial stage of switching. Certain regions of DNA are excised and are joined back together. This process is prone to errors. For example, genes of growth factors may end up in the antibody region and thereby become upregulated. So, let's give you a recap of the previous section. Lymphomas can be classified as either Hodgkin or non-Hodgkin lymphomas. Non-Hodgkin lymphomas represent a very heterogeneous group and can be further differentiated into indolent and aggressive lymphomas. The most important B-cell lymphomas have been briefly presented. For the sake of completeness, we haven't listed any examples of the T-cell lymphomas as they are less common than the B-cell lymphomas. Okay, we've already accomplished a considerable bit up to now. You already have an overview of the acute leukemias and lymphomas. Now we will turn to the myeloid stem cell disorders.